Good afternoon, everyone. Thank you for hanging on. Fully aware this is the last session of a long day, long week. I think we have a superb panel. This is a combination of public and private sector, bilateral and multilaterals, looking at the issue of the translation of integrated prevention campaigns into policy and the issue of sustainability. I'm particularly lucky to have as a co-chair Dr. Nafis Sadiq, who needs no introduction. Most of you remember her as head of UNFPA, Under Secretary of the United Nations, and one of the most distinguished promoters of women's rights and family planning. So I'm very privileged to have you here, Dr. Sadiq, as my co-chair. I will refer to Meet's point, you didn't expect that coming, about the tension between the horizontal and the vertical approaches. And thank you to Erin for having mentioned the National Health Weeks in Mexico. In my previous life, I was a public health servant in Mexico for many, many years. And we coined the term the diagonal approach, which is selected health priorities driving the changes into the health system. So I think the dichotomy between horizontal and vertical is antiquated and unnecessary. I do strongly believe that a diagonal approach allows you to select the right mix of prevention and other interventions according to the epidemiological need in any given country. My role is to keep people on time and then towards the end present some provocative questions. I would like to now ask Dr. Sadiq to give us her perspective of this, perhaps from a regional perspective. She is the special envoy of UNAIDS for Asia. So I hope she can bring us that perspective. Please, Dr. Sadiq.
Can I just sit here?
Absolutely.
Thank you very much. First of all, I think I'm here under false pretenses. I was sent here by Michel to take his place, not knowing that I was going to be in the midst of all these important researchers from the University of Washington. And I'm certainly not a researcher, and I'm not a scientist in that sense. I am a scientist, but not in the sense of a research scientist. So as I was listening to all these presentations, I kept started to think to myself, why am I here? And I kept trying to get hold of various organizers to say, just drop me out because I have no place here. But Jaime was insistent that I have a perspective to present. I'm not sure you'd be happy with my perspective, but here it is. My first observation on this when I discovered what the panel was actually going to be about was, is this the best place to really look at integrated programs? I mean, I don't doubt that the researchers have come up with very important findings, but you know, my own experience has been that the most important programs to integrate with are the vertical programs, but especially in the area of family planning, sexual and reproductive health, and programs that address women's health and gender issues. And there we have some data, but not in this detailed kind of way, and in addressing the three elements that you are addressing. And I was thinking to myself, well, maybe one would have been more successful in pushing this integrated approach if we had such data in such an obvious area where you know that it is important, it is essential, there's lots of duplication, and there are lots of missed opportunities. And furthermore, that the health worker at the field level is the same person who also gets different training, etc., 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 different collection of data, etc. And I was trying to think of what I would say here. And there are numerous examples in Asia of integrated and very well integrated programs in the area of prevention of mother-child transmission, integration of sexual reproductive health, family planning, but not on a national scale and not well researched. There are also very well integrated programs, again, elements of ART treatment and TB treatment, and the importance of community family level support systems, which should go with the program delivery. And secondly, the importance of community-based and civil society organizations, advocacy and participation in the policy making and in the program and in the delivery. And increasing now, one starts to observe in several Asian countries, public-private partnerships, which are really doing very fantastic work, but again in a small area or in small scale, but developing lots of innovations. And I was thinking, why aren't some universities doing research? Research in the sense of analysis, this analytical type of research which is actually operational. I would cut out a lot of the types of findings and go straight to the initial essential findings that actually you deliver better and more, and you capture a lot more. My observation on your research here was that it's so campaign mode oriented, and even though you have these models of replicating and whatever widespread application, in the actual world, that's not what actually happens. And in the actual world, a lot of the programs are driven by who controls the finances and where the people under them are controlled. There's so many other practical difficulties. So a campaign mode somehow goes beyond that, and is like the government has already decided that this program will be implemented and does. But if it's a national program that has to be integrated in the same way, it's not that easy. So I was wondering to myself, shouldn't researchers look at also programs which are not artificially, well, I don't want to use the word artificially, but which are in a research mode, but rather more in a actual life experience mode, where the country, you have to deal with some of these aspects of programs which can become real barriers. So while we all know, a priori and I suppose intuitively, integrated is better and will reduce resources, and in many places capture many more people to be picked up and to be addressed, but in the actual world, why has it been so difficult, even in such a obvious area like family planning, use of condoms, counseling, testing? You see all these vertical programs and so much inefficiency and so much counter kind of information and lack of support. So that's my intervention, which is not very helpful to this very learned research group. But it's an area where I do believe in the value of integrated programs. I do believe in the very important value of preventive programs. I do believe in the strong cost effectiveness of using the very poor health systems in so many of our countries in the most effective way, and to using the staff in the most efficient and effective way to deliver the most. And also, what is called one-stop, but the one-stop doesn't actually say what it is that should be done. And the one who provides the one-stop, what should she or he, and there's so many she's, have to actually do. And those are the things that in my practical world are the things that engage me, and one thinks of all kinds of ways to overcome them. But if we had good research analysis and really observations that could help us, I think one could use all these this kind of information much more usefully and practically. So, while you've done all that,
Thank you,
you might
Dr.
regret it.
So once again, thanks for the opportunity to say a few brief words. And I'll divide it into two. Initially, I was going to talk a bit about the Global Fund and the changes that we've had over the last several months, and I will do that. But first, a few comments on the very interesting presentation that we've heard today. And I guess the fundamental question would be, would it be possible that the Global Fund might invest in IPCs? And to that I would say, I mean, somebody said integration is a no-brainer. I mean, it seems to be a no-brainer. But from the position of the Global Fund, we're at the moment we're demand-driven. I'll tell you about the new model in a moment, which means we rely on country ownership and countries to decide what interventions they want to do. And we also rely on our normative agencies. We're not a normative body. So in terms of if there was normative guidance and it was felt by countries that, based on the very good evidence that was presented, they wanted to include some of these packages of interventions, and I think that would certainly be possible. We clearly fund just the 3 diseases, and there's been a lot of debate about that, and health system strengthening. And so from the first model of integration, obviously first look would suggest that we would fund 2 of those interventions, but there's always scope for these things at country level. I just wanted to give you some results from our latest results report, just to highlight the scope of what we've been doing. So our latest results suggest that we are funding 3.6 million people on antiretroviral therapy. We cumulatively have distributed 270 million bed nets and have treated just over 9 million people with tuberculosis. So obviously, with PEPFAR, we're one of the major funders in this area. So just in terms of some of the changes over the last few months, we've clearly had some transformational changes, and I've been at the heart of that, and some of it's been very difficult, as you know. Part of the reason for that is to bring the Global Fund back to its core business, which is about managing grants. And what we're hoping to do is to manage these grants much more impeccably. And some of the key changes include moving human resources, 75% of them, so that they focus on grant management. That's both in a newly created grant management division, but also in the strategy, investment, and impact division, which is where I sit. We currently have over 500 active grants in 151 countries. We've prioritised these to focus in 3 high-impact zones, so that 21 countries, which account for 65% of our investment and 70% of the burden of disease, gets the most focus in terms of human resources. I'd like to focus on 3 additional areas. Firstly, on reprogramming. So the Global Fund, as has been thought by many, actually has substantial amounts of funding. We estimate that in the next 2 years, we will have up to 9 billion of funds which are going through this reprogramming process, which is when we first committed money to a grant, we committed to 2 phases, a period of 2 years and a period of 3 years. And so we have £9 billion which is committed but not allocated, and that allows countries to reprogram, that is to move funds to what we're identifying as high impact interventions. So for example, if it was felt by a country that interventions such as being presented here today were of high impact, and the country could move money from one from one service delivery area to another. The other thing I wanted to mention was our new funding model, which is under development and consultation as I speak. In fact, there was a consultation today, I'm on yesterday. And what we're describing, what we're trying to do is to have a new model, whereas in the previous model, when there was a proposal, it got submitted to a technical review panel, and that panel gave a yes or no answer. The new model is a two-stage process where there's an initial, very brief concept note submitted to by the country, which then enters into a dialogue with the Secretariat and the Technical Review Panel to improve that proposal. So the time to implementation and the time to dispersal is shortened. The final thing that I would say is that the other big change is that the Global Fund is working, trying to work much better with all our partners. We've established 3 disease committees which allow partners to sit once a month with the Senior Management Committee and to look at our investments and help us program investments according to the identified bottlenecks and the best information that we have to date. And we've also opened up the Phase 2 panel, where we have partners sitting on a panel who can also advise on the grant submissions. So that, in summary, is some of the changes. We've been working very closely with PEPFAR as well to make sure that we align our investments with them. I think there was a session on Sunday which looked at that. And I think with that, I'll stop there. Thank you.
Thanks so much. You know, after listening to Aaron Van David's talk, I'm really just tempted to say what he said, but I know you're not going to leave me. Let me leave here today with those kind of remarks. But he truly did do a very good job of outlining the situations of the donors, especially in this type of funding environment at this time. So thank you. Made my job very easy. I'll keep my remarks very brief tonight. So we'd like to very much thank the organizers of this session for inviting us to participate in this very interesting and provocative panel discussion today. So the kind of integrated interventions that are being discussed today are an interesting model for how we as the USG with other donors could coordinate across sectors where appropriate, bringing together interventions in HIV, malaria, and clean water to provide a one-stop shop approach. We very much appreciate the modeling work done by Jim Kahn and colleagues and the other studies that were presented today that show the potential impact of these combined interventions. We find them very promising and very exciting. But I have 3 thoughts to share on behalf of the technical teams at PEPFAR with whom we've shared your work and had some rich discussions amongst ourselves. So first, we're very much interested, as my colleague and co-chair to the right has discussed, in seeing more data on the impact of these interventions in actual communities as is and as not as a study, but as they're being rolled out. And we really think these will build on the important information gleaned from these studies and modeling. So, and this is especially important in this context, and Aaron, discussed this before a little bit and alluded to this. So as you may know, PEPFAR over this year has made a pivot to increase its focus on evidence-based interventions to stem the HIV epidemic, and we're increasingly accountable to have very high standards for evidence-based interventions across our portfolio. And this is especially true in this very static funding environment that we're seeing now, with very ambitious goals in PMTCT, treatment, voluntary male circumcision, and condom distribution. We think one potential interesting way to measure impact in the PEPFAR realm would be to partner with PEPFAR country teams to test this approach through implementation science mechanisms. So we would really welcome partnering in that way to see how this really works in the real world setting. And second, I suspect that the reason we're invited to a lot of these panel discussions, and the elephant in the room is always, will you fund this? So as most in the audience know, PEPFAR does not make normative guidance like Global Fund. To that we look to WHO. But what PEPFAR does is we support national HIV programs. And we support programs that include a variety of interventions directly related to HIV. And the mix of these interventions vary country by country according to the epidemic and region. And the people who make the decisions about these interventions are stakeholders on PEPFAR country teams, national governments, other stakeholders who are often driven by advocates. A lot of decisions are driven by advocates in the advocacy community as well. So how could these interventions that are integrated possibly be funded by PEPFAR? What we propose is that we could coordinate with other agencies within the USG, and we could possibly fund HIV-related aspects of such interventions and partner with USAID, partner with PMI to sort of implement these and work together to implement these integrated campaigns. And we actually have been successful in working together, believe it or not, before. Especially, and one example of this is in the provision of family planning services in PEPFAR clinics, where we've coordinated with other donor with other donors and within the USG to provide these interventions. And Aaron referenced a little bit the Global Health Initiative, and I'd just like to defend it a bit. It certainly has had its challenges, but in developing the strategies in country for the Global Health Initiative, we've brought together members of our USG team from PEPFAR, from USAID, from PMI, in putting together these plans and creating these plans. And we really think that they've fomented a lot of synergies and exciting plans to work together on issues such as health, in areas such as healthcare systems, supply chain management, et cetera. So we can talk a little bit more about that. And lastly, I'd like to pass along a point from our counseling and testing folks, and I think this was also mentioned by my co-chair to the right. One of the significant challenges from PEPFAR's point of view is getting patients linked to appropriate follow-on services. So in this example of these types of integrated preventions presented today, HIV positive individuals identified in these campaigns need to be effectively linked to care and treatment. And patients identified as negative might be best referred to voluntary manual circumcision providers or other risk reduction activity. And we would like to stress that the key is not just making these referrals, as it looks like has been done quite well, but in seeing that these are completed and that these patients are actually retained in these services. So one idea we would like to propose is whether or not it might make more sense to integrate some of these types of activities in some settings into services or into services and events at the actual healthcare sites. So having events at the site, so they're a bit more closely linked. And this is also something that we would suggest that might be an idea to, or well explored through an implementation science mechanism. So we look forward to a rich discussion today. These are just a few thoughts that we have.
Good evening. Thank you for giving me the opportunity to say a few words about the role of the private sector in integrated prevention campaigns. I'm part of the Global Health Group at UCSF. So just quickly, I'm going to talk about first why we should focus on the private sector. It might not be obvious at first that the private sector has a role to play in IPCs, and then I'll talk a little bit about private sector actors specifically and how they might potentially play a role, and then focus a little bit on the social franchising model as one way in which we see these IPCs as potentially becoming integrated into the healthcare system as it exists already. So why do we care about the private sector? Well, it turns out that the majority of people in developing countries actually are treated in the private sector. So in Kenya, that number is 58%. In Nigeria, it's 65% and 78% in India. So this is referring to treatment, but because this is where people are seeking treatment, it seems highly important that we not just focus on the public sector to deliver prevention campaigns, and that we make use of this existing infrastructure to carry out IPCs. So this includes all private sector actors. It's private clinics, hospitals, the informal sector, and also NGOs, although surprisingly to many of us, NGOs play a smaller role than many of us assume. So what are some of these potential private sector roles? So on the side of inputs and commodities in IPCs, we have private sector companies that can produce high quality and low cost commodities and drugs. We've seen this investment in mass production of drugs lower the cost of ART and malaria treatment, and as Vestergaard Branson has done with bed nets. And then NGO partnerships in country often work on the supply chain side, and an example of that is Nets for Life to do delivery of commodities. On the support, data collection, and information dissemination side, so this might be applicable to pre-campaign activities, we have numerous pharmacy, drug outlets, and chains and drug detailers who are increasingly playing a role in prevention and in educational activities. So GlaxoSmithKline, for example, has started using their drug detailers to disseminate information while doing drug detailing and selling products. Technology companies can be used for cell phone reminders and other informational tools, data collection. And then specifically on the implementation side, we have corporate-run networks and campaigns and for-profit clinics, hospitals, and pharmacy chains that are increasingly playing a role in delivery. So it seems to make sense that we should utilize those networks for prevention campaigns as well, rather than sort of reinventing the wheel and setting up new sites to do delivery of these bundled packages of preventative services. Specifically, social franchises is one thing that I would like to just point out as an innovative model that we might consider for deployment of IPCs. So what this means is that we have numerous clinics, independent clinics that are operating for-profit in communities globally, and a franchisor comes in, which is often an NGO, local or international, that networks these clinics together, provides branding, training, standards, and commodities, and the franchise clinic then is required to follow certain quality standards and implementation procedures and feeds data into the system. So we're learning a lot about cost of delivery and DALY calculations, health impacts that we didn't know before. So just to show you the scale aspect of this model, this is a rapidly growing approach that is now happening in over 36 countries and has doubled since 2006. And many of these networks alone, there are over 50 that we know about around the world. Many are serving tens of thousands of people. And they're integrating more preventative services. So they're integrating HIV/AIDS testing and treatment, TB, active case detection, malaria, case detection and treatment. And so they're already doing many of these activities and employing community health workers in many situations to go to rural areas and actually start educating people at a preventative level. So it seems to make sense that we could utilize these networks to implement IPCs. Funding is the key challenge, though, of course, as others have pointed out. These are private providers who are motivated by profit, and so we need to think about innovative ways to integrate them into the network. But there is more and more demand-side financing, voucher programs, and other ways in which we can make these networks work for preventative campaigns. So to summarize, there are many innovative ways to engage the private sector in IPCs. Funding is the biggest challenge, but we really need to overcome this because the private sector is crucial for healthcare in developing countries. Thank you.
First and foremost, thank you, Mr. Chair. Just a quick background on my company, and if I speak fast, I can still maintain the 5-minute limit. Vestergaard Branson is based on what we refer to as humanitarian entrepreneurship, and that is, for us, means that we aim to save lives through innovation, and by harnessing market powers to improve lives of people in the poorest nations. What we're probably best known for today is the invention of the long-lasting insecticidal net, and being the first company to take that to scale, and thereby having assisted our partners in the public sector to have a significant contribution through the distribution of long-lasting insecticidal nets in the annual malaria death, which has come down from more than 1 million 4 years ago to less than 600,000 last year. We're also very active in neglected tropical diseases, and we've been partnering with the Carter Center for the last 18 years in the guinea worm eradication program. There are 4 countries left, and this is potentially the second disease to be eradicated. More importantly, the first to be eradicated without the use of vaccine. One of the key tools in this campaign is a water filter that we invented. We started developing the integrated prevention campaign that you've heard about for the last 1.5 hours back in 2006, and we launched it as a private sector-led initiative in partnership with CHF and Ministry of Health in Kenya. We launched it in Western Kenya on September 16, 2008, a date that's also famous for the collapse of the Lehman Brothers, which spiraled the world into a more cost-conscious state and serves as a very important reminder how we need to maintain focus on getting more done for less, and maintaining that high on any public health agenda. But when people in public health speak of innovation, it's often about technology innovation and much less about innovation delivery, let alone management innovation. And I think that today has shown the case for innovation in public health that's beyond technology development, and how we in integration can provide effective health tools and let them serve as an incentive for increased uptake of services such as VCT, and thereby increasing the coverage and leading to early detection. We've also seen how through integration we can create efficiencies in delivery and scope, efficiencies in delivery and efficiencies in scope, and how we can reduce the cost both per unit and the total program cost. We've only touched the tip of the iceberg when it comes to integration, and we've seen as we've generated data, or as our partners have generated data in this IPC, how we're also having an impact on stigma as we integrate a stigma-related disease with 2 non-stigma-related diseases, and how the increased coverage has improved access to the hardest to reach population and increased the likeliness of equitable access. I want to spend my last 2 minutes, I think that's what I have, just touching very quickly on another campaign we did, because it's relevant for HIV. We integrated diarrhea prevention and climate change, of all things. In May last year, we installed 900,000 water filters, nearly 1 in every home in Kenya's western province, benefiting 4.5 million people. We also educated people and communities that when they filtered water, they reduced the need for boiling water and burning firewood. So as the technology has been adopted and behavior has changed, the program has resulted in 2.7 million tons of carbon credits, which can be sold and has generated finance, sustainable finance, for the free distribution of water filters. We're doing a case control study among the most vulnerable population, and we're seeing statistical significant decrease among children under the age of 5 presenting with, in the odds of presenting with diarrhea or dehydration. And we're now beginning to study, beginning a case study among HIV positives. But the piece of this that's really relevant for HIV and for the audience today is the pay-for-performance part of this campaign. Everyone who's ever worked in public health has, or been at a public health conference, has heard the conversation about how, how come Coca-Cola can reach this village and that guy and this kiosk and put a Coke bottle on the top of Kilimanjaro and we can't do X, Y, Z. The answer is very simple. Coke doesn't get paid until they reach the end user. So similarly, in the Carbon for Water campaign, or in our integration of diarrhea prevention and climate change, we were not paid a single cent until we, with very highly regulated monitoring, had documented that the technology works and people use it often and consistently. So this is relevant for HIV because the integrated prevention campaign, which we've been talking about for a couple of hours now, offers a similar pay-for-performance opportunity where an upfront investment can create significant financial value through the implementation, or through the results of the implementation. So I want to just close by challenging the donors a little bit, because I do think that a vision a long-term vision for donors ought to be to no longer upfront money and hope for the best, but to buy shares in an impact or an outcome that's already documented, or to at least make strategic contributions with return of investment, because with a program like IPC, that is possible. And particularly, if we ever want to graduate from aid, we need to think about innovations like the IPC. Thank you.
Thank you, Miguel. Let me ask Dr. George Greer here, his perspective from PMI. I'm going to ask Lara and Dr. Sadiq about their perspective on how to integrate family planning into what we are doing in AIDS prevention. And let me ask Miguel for your views. Are we having the right balance between the supply side and the demand side of the equation? George, please.
What a great afternoon or a couple of hours. I think the wonderful modeling and research that's been going into this, and then the more practical side that we've heard from this panel really are complementing this whole idea. And from a PMI perspective, I think my colleague from OGAC very well summed up what the USG's positions are. PMI is very willing and eager, and we are collaborating as much as we can through some new initiatives we have, particularly in Nigeria, Ethiopia, and DR Congo, with PEPFAR to look at better ways of collaborating together and integrating our programs. And I like also our chair's position on diagonal. And I say that because I think we are getting a little weary in the PMI world of campaigns, not necessarily the type of campaigns that are looking at prevention within the HIV world, but the delivery of dead nets is not an easy thing through campaigns. And we're learning over time that if we can finally get to a point where we can continuously distribute these, it would be a step forward for us. But in doing that, we still look at opportunities to integrate. That's why I think if we can figure out a way somewhere between the having every 3 years to deliver 60 million nets in Nigeria, which has actually taken more than 3 years to do, we would be in a better position both in terms of the human resources that it takes to do that and refocusing their activities so that they're delivering nets at the community level, along with maybe perhaps vitamin A or some other commodities that can deworming and whatever. And I wanted to go back real quickly to point out that one of the first, I think, mass campaigns, certainly for bed nets, and I think for integrated approaches, was led by IFRC and the vaccination group that led by Mark Grabowski in, I think, 2007, where they said, we're doing a measles campaign, let's add some ITNs to go along with it. And that led to many, many more campaigns along the way. But as I say, we're getting a little weary, and we'd like to, in the PMI world, we're all for integration. We have been and will continue to do campaigns, integrated campaigns, until we can figure out a methodology that reaches a more diagonal angle on that.
Thank you, George. You get points by advocating diagonal approach from now on. Hafiz, would you care to comment on family planning and AIDS prevention?
Well, I think I already said some at the beginning when I was speaking. I think the family planning programs are a very natural place. Most of the condom supplies come from the family planning programs in at least most of the Asian programs, but I think even to some extent in the Africa programs. And if the family planning, counseling, etc., is only for prevention of pregnancy, it sort of defeats its purpose. It should be to step back. First of all, most of the programs are focused on married women, and delivering services to women who, are already in not to prevention services. While they talk a lot about adolescents, they're still not targeting adolescent young men, maybe, but certainly not young girls. They're not reaching out to people living with HIV. They don't reach out to sex workers. They don't reach out to MSMs. So they're really not, the slogan is reproductive health and sexual health for all, but in fact they're reaching out to a very limited population. They need to expand the scope of their programs to embrace all of these groups and find a way to get them to the program. I think therefore they can't be just linked with maternal health services, because that immediately limits it to, in many countries, to married women, but at least to pregnant women. And I think the idea of family planning is that it's not necessarily, it's not a clinical service. It's for people who are not ill or don't require medical intervention. They just need to find a way to prevent a pregnancy or to protect themselves from it. So I think that we have sort of, our thinking is quite, is not straight on this. We say it, but we don't actually implement it in works. Secondly, on the sexual and reproductive health program, which is where the family planning programs are now, based, they don't actually deliver sexual and reproductive health. They don't do sexuality education. I mean, a lot of the programs, some do, but in a very intimate kind of way. They don't reach out to the populations that actually need these services. So it needs a whole mindset change. It needs a whole attitudinal change. And we need social activism to be much more involved. In fact, the women's groups, for example, have been a problem. They advocate abortion, but they don't recommend family planning. They don't want integrated services, because then, the women's angle is somehow reduced. So there are so many obstacles rather than so many, evident ways in which we could really make our programs much more cost effective. And in the case of both HIV and pregnancy and sexually transmitted disease prevention, which are the objectives of several of these programs, we could do them all together.
Yeah. A 1 minute comment, Clara?
Okay, I'll keep it less than that. I'm certainly not a family planning expert, and I think that this question would probably be better answered by some of my USAID colleagues in this room. So pipe in as needed. But I think this is an issue that we're being really pressed with, and is really important to us. And we heard it even from Secretary Clinton in her very progressive speech on Monday. So I know that we'll be thinking about this more and more in the PEPFAR realm. There are some funding restrictions with family planning within PEPFAR. So what we've done in the field is coordinate our funding. We do feel that it's very important to have access to family planning services. So what we've typically done is work with USAID and other donors in the provision of these services at some of the same sites where we provide treatment and care services. So I think we need to be doing an even better job than we are with doing that moving forward. It's something that we're very much committed to.
So I will leave Mikael the last word, but let me take 1 or 2 questions from the floor. Please.
So, yes, it's actually more of a comment from the WHO perspective. So, a great panel, I really appreciate the policy focus. I just want to be really clear, these interventions are actually already recommended by WHO. So what's happening here is that they're being put together, and that's what's new. We have a new counseling and testing framework that was just released, and it's on our website, and it actually mentions multi-disease prevention campaign. So I would urge us to move probably less in a research direction and more in an implementation direction while we're researching. And so my question or my plea to the panel is that actually I would argue that the recommendations in the policy framework is there. What's needed is actually the coordination. And you have a situation where donors are maybe a little bit hesitant and the government's a little bit hesitant to go. This is a coordination issue basically, and a government probably needs to step up and say, look, we are going to do these things. They're recommended by WHO. We're going to put them together in a campaign. and then donors would need to work with the government if financing is necessary. But in terms of recommendations, I wouldn't wait for WHO in that regard.
I agree. There's one piece missing, which is the evaluation component. I think we need a little bit more evaluation to make the case more stronger. Okay, Mikhail?
I think Ruben's remarks should have been the closing remarks. but I'll be happy to just add a quick comment on the supply and demand. See, the thing is here that the IPC is the perfect tool to balance out supply and demand because one serves as an incentive for the other. And mind you, the history behind this is that is exactly as George Greer mentioned. Back in 2002 to 2005, we're exceptionally good at getting bed nets into integrated child health campaigns, integrating it with measles vaccination, vitamin A, deworming campaigns, and so on. And suddenly there was a call to get not only bed nets out to a biological target audience of children under 5 and pregnant women, but also to all at risk for malaria. And we were thinking, how do we get bed nets to adults? And at the same time, we were seeing how not enough people were getting tested. So the combination of that was blindingly obvious. We integrated water filters into this because it was one of the least funded of the public health tools out there, and probably one of the lowest hanging fruits in quick gains on a number of public health fronts. So today we're now being we're being contacted by organizations who are interested in using the Care Pack, which was the tool that combined the BedNet, water filter condoms, and health education, a similar Care Pack, as incentive for cervical cancer screening, as incentive for circumcision, as incentive for a number of things, because it balances out supply and demand. Thank you.
Okay, thank you very much. Have a good night, and thank you for being so patient.